Good afternoon, people. I'm Dr. Robin Pinto, cardiologist from Mumbai, and today it gives me great pleasure to talk with and discuss the future of echocardiography with Dr. Richard Chazal from Florida, USA. Dr. Chazal was the past president of ACC, and to no one's surprise, trained with the great Richard Harvey, Dr. Harvey Feigenbaum. He currently is Director of Health at the Lee Health Institute in Florida. Good afternoon, Dr. Chazal.
Such a pleasure to be here.
So, not to talk about echo, but of your trip, this trip to India, has it been rewarding, fruitful, interesting?
Fantastic experience. We've had an opportunity to enjoy the people, most importantly, the food. I need to leave here before I gain another 50 pounds. But we saw the Taj Mahal, the most beautiful building in the world, I'm convinced. Fantastic experience.
And built for love.
Built for love, the only monument built for love.
And is this your first trip to India?
I had been here several years ago in Hyderabad, so couldn't wait to come back. I love everything about it.
Coming back to medicine and echo, you have worked from pioneering work in echo, and has it taken you the full circle, or what has happened to you in all these years?
Well, I was initially trained as an academic echocardiographer, but diverged from that a bit, and one sometimes comes back to one's roots toward the end.
What I want to discuss today is the future of new technologies. We are all used to transthoracic and color Doppler and spectral Doppler, and we're so used to these images. But there are so many new technologies coming out, and we'd like to spend some time for the upbringing and upcoming cardiologists. So what do you feel have been the most exciting new technologies in echo in our field today?
Well, if one looks even over the last 5 years at the difference in the way we utilize echo, not just imaging of structure and movement, but now looking at physiology, particularly in areas like heart failure and cardio-oncology, we're utilizing Doppler technology to measure diastolic function and to estimate pressures. Weren't able to do that several years ago. Being able to use speckle tracing to measure strain, giving us an incredible window into function at a level that we couldn't discern before. We're utilizing more 3D echo, and of course, increasing use of transesophageal echo, which has become universal.
Of all these technologies, you mentioned speckle tracking. What do you see the future of this technology? It seems exciting. I still feel it's early days yet. I don't know, what are your thoughts on this?
I think that it is in the early stages yet. And yesterday, I was speaking about right ventricular function, and we're starting now to get data that on strain in the right ventricle as opposed to the left ventricle, and it turns out it provides a tremendous amount of prognostic value. So I think that the sky's the limit here as both the technology and our leveraging and utilizing the technology improves.
I think all these years we are used to a very, what we call eyeballing ejection fraction. It was not an exact, very subjective evaluation of LV function, which is such an important aspect of echo. Half your guidelines depend on ejection fraction. And I think spectral tracking adds a lot more objectivity to that criteria.
I couldn't agree with you more. And even beyond that, the use of contrast echo enhancement combined with 3D echo changes everything. Because now one can really get a better global sense of what's going on with function without the problems of wall delineation. So if one combines that with the strain information derived from speckle tracking, we're really on the cusp of moving much further along.
With speckle, I don't know, sometimes I think you need a good image first of all to get a good spectral tracking. But are all the machines sort of the same? Is the technology uniform in machines? We should have this problem with angiography.
Yes.
But is it the same with speckle, or is it going to change in the future?
Well, one hopes that there'll be more uniformity because there is some heterogeneity between vendors.
Right.
And so it's important for all of us to realize that particularly in determining normal limits, it's based on the particular vendor that one is using. And so if you change from one to another, you need to be aware. You hope it becomes more universal. Yeah.
When I do speckle, I do a lot of speckle. I use it basically for GLS. How good you think is speckle tracking in diagnosing ischemic and regional wall motion?
Yeah. So I believe that we're on the cusp of this as well, and you've alluded to, because just as we've learned that there are certain things that happen in early ischemia before one can visualize wall motion abnormality, and we've learned particularly from the cardio-oncologists that there's reduction in systolic function measured by speckle tracking with strain rates before an actual drop in ejection fraction. One can also surmise that you may be able to begin to detect ischemia earlier by utilizing that modality.
But I think that's not state of the art yet.
I think we don't have enough data yet, and but one could certainly surmise that this is really an area that will be ripe, and we're starting to see this come out a little bit.
And as regards oncocardiology, is it taken off in a big way? Like, for example, in the US, do you necessarily, when a patient referred to you, have to give this data when you follow these patients on chemotherapy?
So it's a great question, and actually it has taken off in the US enough that this has almost become a subspecialty of cardiology. So we now have cardiologists that are identifying themselves as cardio-oncologists. They work very much in concert in a team-based fashion with the oncologists, and at least in most centers, speckle tracking with strain is a standard part of the exam in patients that are receiving at least certain chemotherapeutic agents.
And when you report this, what do you take the absolute decrease in global strain, or you take a cutoff value normally?
I think there's, again, heterogeneity in reporting. I know in our centers, we're actually numerically giving the differences and then an interpretation of what we believe that means. And there are some standards that have been set that talk about percentage change, but I think, again, this is not as well established yet.
Dr. Chazal, it intrigued me. You alluded to LV opacification and contrast. I think that's another field which in India too, when we do dobutamine stress echo, many centers use this routinely.
Yes.
And I think it enhances your diagnostic skills and your certainty of regional wall motion. Has it been taken off in the US in a big way?
It really has, and I still think, however, as much as it's increased in the last 5 to 10 years, I still don't think we've seen the full development and utilization of this technology. The ability to opacify both the right and left ventricle is extraordinary, and we're starting to focus a little more on the right ventricle, the forgotten ventricle, if you will, and often very difficult to see. But with contrast, one can really begin to see these enhancing agents help. Beyond that, though, there may be some future use in looking at myocardial perfusion, not FDA approved at this point in time, but an area for the future.
I was going to tell you, it's great for opacifying the cavity. I think we are a few years away from making it routine for perfusion. A lot of my colleagues in Bombay use it for viability.
Yes.
I think it's quite a good developing technique for viability, and it's always an issue here. You have an anterior wall MI, you don't know whether you should revascularize him, and I think this helps in a big way.
Absolutely.
Another fabulous and fascinating technology is 3D echo. And again, I feel it's dramatically underutilized. I too, myself, in my practice, I hardly ever use 3D, though I have a machine for that. I don't know if it's a time constraint of practice, but what is your feeling? What is the future of 3D?
I think it's an untapped resource at this point because so many echocardiographers were not trained in an era of 3D. So we have to go back and relearn techniques. Our technicians have to do a little bit different work, and we need to begin to visualize the heart differently than we did in 2D, just as we had to initially figure out what the 2D images look like.
Right.
But this is an untapped resource.
I attended part of your lecture, I was busy, but just to talk about the forgotten ventricle, the right ventricle. I mean, there's so much data now and so much emphasis now on the RV side of things rather than the LV. And do you find that strange or it's good for cardiology?
I think we have to.
Yeah.
We've focused, if one thinks about, for example, heart failure,
Yeah.
for years all we talked about was systolic function, the ejection fraction.
Correct.
Now we recognize more about diastolic function. In heart failure with preserved ejection fraction. And I think now we're beginning to shift over and say there's a tremendous amount of information to be derived from what's going on in the right ventricle as well.
I know the cardiac surgeon, one of them, he's not interested in the left ventricular function. Tell me, is the RV okay? If the RV is okay, I'm going to operate this patient. The RV is down, I prefer to wait. And
I think that's a very forward-leaning thought because I presented some data yesterday where some early data is suggesting, for example, that strain rate in the right ventricular free wall may be more predictive of what happens in heart failure patients than our other indices. That's fascinating. Yet to be validated in other studies, but how fascinating is that? And that would validate your surgeon.
Exactly. Another interesting field is the use of artificial intelligence. We are seeing it being used increasingly in our day-to-day lives. You have Alexa, you have Google, you have this, X-ray reading. What's the future of echocardiography?
There have been a number of papers, and one in particular recently published, that looked at a study for beginning to read echocardiograms with machine learning or artificial intelligence that really looks very much like this is going to take hold. And you and I were discussing earlier that in our country, we believe that diagnostic radiology is a dying field. And could we find a near future, because of the exponential growth of the computer technology, that many of the echoes, particularly normal or fairly simple echoes, would be interpreted automatically by a computer? And perhaps, I hate to say this, perhaps better than you or I, but in reality, leveraging the experience of thousands of cardiologists.
Yep, I hope we're not out of jobs.
I hope not too. But I think we need to plan for that and evolve how our practices go so that we're not caught surprise.
One last aspect of the future of echo is the miniaturization of everything.
Oh, yeah.
And though it's not taken off in India in a big way, but we also hear handheld echo being given to all the residents now in the US. They have it in their pocket. They go bedside and they put the probe and they diagnose everything, at least some of the important things. What do you see the future for that?
Well, my close friend Jagat Narula made a compelling comment that the stethoscope is dead. And I think that he was really making a point more than anything else, that the ability to image at the bedside is a dramatic extension of our clinical tools, our stethoscope, our eyes, our ears, our hands. And there are now, as you may know, probes that literally fit on the tip of one's finger so that you can get images, and the potential for having something the size of your cell phone where one could get images. So that ability to very rapidly get ideas about a pericardial effusion, left ventricular systolic function, some valvular information, and who knows, maybe strain and diastole. But this is really going to be a growing area.
I think if there's money to be made, the companies are going to put all their research into this.
Well, you know, at one time, I'm certainly old enough to remember that none of us had cell phones. And we couldn't imagine a time when everyone had one in their pocket. And really, if one thinks, the technology for handhelds is such that one could conceive a near future where all cardiologists, maybe all physicians, have an ultrasound in their pocket.
It's been fascinating talking to you, Dr. Chazal, and an honor and proud privilege. I hope you have a wonderful time in Mumbai. And for all the people who attend CSI, this is going to be the future of echo. And hopefully we're not out of jobs. And if we are, we better start looking for alternative forms of having money. Thank you so much, and good night.